of the abstracts I thought was most significant was the new data from the FLEX study, which was a study that looked at cisplatin vinorelbine chemotherapy, comparing it to cisplatin vinorelbine with cetuximab, the antibody to epidermal growth factor receptor. And we had first heard about FLEX at ASCO, 2.5 years ago, and the data have just sort of languished. Nothing as much happened. But now there's been a reanalysis done, where instead of just looking at the presence or absence of any epidermal growth factor receptor staining in the specimens, there was a continuous scale used to quantitate the amount of epidermal growth factor receptor in each tumor. So using a cutoff of 200 on a scale from 0 to 300, about 31% of the patients had high EGFR staining and 69% low. And in the 31% that had the high EGFR expression or staining, the hazard ratio for survival for adding the cetuximab to cisplatin vinorelbine was 0.73. That's much better than the 0.87, 0.8 plus that was seen, at ASCO. Now, this is a retrospective analysis because the cutoff was determined after the trial had started, but still it suggests that there might be ways of identifying groups of patients who benefit more from cetuximab. I'm particularly interested in that because in the Southwest Oncology Group right now, we have a trial known as SWOG 0819, a 1,400 plus patient trial. It's actually looking at chemotherapy with carboplatin paclitaxel with cetuximab, including bevacizumab in appropriate patients. And we're actually looking to see if FISH, or gene copy number of EGFR, correlates with outcome. And we're now going to add the protein level into that trial because I think that it gives new hope to potential uses for this drug in lung cancer patients. So I wouldn't use these data to manage patients currently. It's always dangerous even when you use a cutoff for a biomarker by immunochemistry that's determined post hoc, because you look at the data and you determine where the data split. So it's sort of a self-fulfilling prophecy. You divide the group up and you see a good and a bad group. What it does, though, is it generates a hypothesis that now needs to be looked at in a test set and a validation set, and that will hopefully happen. And what I was alluding to is that we can look at this in our SWOG 0819 trial, which actually is already ongoing, an NCI-sponsored trial, and I'm sure others will look at it, as well. But it actually, is what we know, that targeted therapy requires a marker, and for colorectal cancer, it's the absence of KRAS that's being used, for the use of cetuximab. We looked at that in lung cancer, and numerous investigators in our SWOG trials and the FLEX trial, KRAS never was seen as a negative factor in lung, but it looks like the immunochemistry might have some potential, but it needs to be further validated. I would not, as a clinician, which I am in a busy practice at Yale, take a patient and treat them with this combination off of a study at this point. I would only treat them on study. Another interesting abstract was out of Amsterdam, actually, where they looked at labeled erlotinib with carbon-11 and did PET scanning. And they actually used that as a way to non-invasively explore patients who had EGFR gene mutations, because the uptake of the C11 erlotinib was much higher and the PET signal higher. And it's still a very early study, but I think they were able to show that they could identify patients who had EGFR mutations, and also they were able to look at the decline in that PET positivity with treatment. And the reason why I think that's important is we've seen at this meeting time and time again how personalized therapy has really gone to the next level, where we're taking these new agents or combinations of agents and we're matching it to the right patients, in many cases doing biopsies. But many of these biopsies are problematic. In lung cancer, oftentimes you'll have a fine needle aspiration, you'll have a few cells, you might not have enough tissue to make DNA to do some of these new analyses. So if you can do non-invasive imaging to do it, I think that would be extraordinary. It also gives you a more dynamic and fluid real-time assessment. You're not just getting tissue from one point in time, you can do the imaging more frequently, because I think it's going to be hopefully less expensive and clearly less invasive on a patient. So I thought that was very interesting as well. But I thought what the group suggested was it was both a way to diagnose the presence or absence of a mutation, and then to track non-invasively the course of treatment. It's still very early, but I think just the whole principle was one that I thought it would be interesting to highlight. I think people will, it'll have to be something that becomes commercialized, because there are all sorts of regulatory issues, especially in the States.